therapy, transpermanent epidural steroid injection, the regular that we see in our clinics every single day. Now, if you take a look over here, you can see that clearly she has a pars fraction, she has a grade 1 spondy. Actually, when she's doing flexion extension view, she's actually getting to grade 2 spondy as well. All right? So we'll come back later to that case. And this is her MRI. You can see that she already has degeneration that's happening at the L5S1, and even when she's lying on her back, she's not fully reduced to the back, so she still has the grade 1 spondy on the MRI on the MRI as well. Now, when we're talking about MIST, when we tell our patients, we tell them that we're doing those surgeries through a very minimally invasive approach. We're going to have a skin cut that's that big, that we're probably going to go home with a Band-Aid. That's what patients believe. That's how patients buy this surgery, and they believe that they want to get that small scar. But the truth is, MIS surgery is not just about getting a small scar. It's not about moving from a huge scar to a medium scar to a very young patient. For the majority of the time, the patients that we are dealing with in our clinics are actually those old, frail, obese patients who have a lot of comorbidities. Those are the ones that we are dealing with every single day in the office. And those are the ones that they don't want to keep them on the table for a very long time. They don't want to keep them in the hospital for a long time as well, because they tend to have a lot of problems, hospital-acquired infection, pneumonia, you name it. This is what we're dealing with in a real life. Now, the problem with those is that when you start doing MIST, that you realize that your OR is becoming very busy. And let's face it, so if you're doing MIST, if you start realizing that you need to have that C-arm coming across the table, you're having the neuro monitoring going across the table. If you're using neuro monitoring for those surgeries, your strap tech is over there, your assistant is trying to figure out a place for him over there next to the C-arm to help you across the table as well. It's not really that easy. It takes time to get to the momentum and to understand what works for you and what doesn't work for you. And the truth is, if you're using a microscope as well for those cases, because your wound is that big, then it gets even busier and busier because you don't have a room that can accommodate all of this. But that doesn't take away from the fact that it is an amazing surgery. Now, a number of years ago when this surgery was introduced, everyone was talking that when you're placing per screw, there's a much higher chance of injuring the facet above, and that results in a higher rate of pseudoarthrosis or a higher rate of adjacent segmental disease of the left above. Everyone did believe that. But actually what Shiraz Qureshi did from NYU, he conducted a cadaveric study a number of years ago. And then he realized that you're using the trajectory of your screws in line with your transverse process. It is highly unlikely that you're going to touch that facet above anyways. So all of that myth that MIS would cause a higher rate of adjacent segmental disease is actually a myth. It's not reality. It's all about the technique and how you place your screws as well. Now, very important to realize that you're not using any midline incisions anymore, and your trajectory is basically aiming for that facet over there. That's your entry point to the disc space. So you're using a paramedian approach or a Wilsey approach, which is usually 4 centimeters away from the midline of your patient. Now, the most important thing as well is that you need to be directed all the way to the disc space. This is the trajectory. This is what you want to target. You cannot be targeted to the vertebra above or the vertebra below, because you're going to lose your trajectory, you're going to lose your direction altogether. Now, there are two ways of doing this. Two types of retractors out there in the market: the tubular retractor and the pedicle retractor. MIST did actually start with that tubular retractor. Now, the most important thing is that you need to land that initial dilator on the facet. Remember, if that's your only mark, that's where you want to be. And then you continue by passing the next dilators up till you pass your retractor in place. The majority of them in the market will come with light sources, because remember, you're working through a tube, you need to have enough illumination inside. And then once you have placed everything in place, you're down on that facet and you can start doing your TLIF. Now, the other part of retractor, which we're going to be demonstrating today in our workshop, is what's called the pedicle retractor. And I like those more, and I moved to those 5 years ago in my practice. Now, the idea of those is exactly like doing an open TLIF. So you're placing your screws initially, not just scale wires. You're placing the screws, and you're able to distract on those screws and do your facetectomies now. So it's exactly like doing an open TLIF, but through a minimally invasive approach. And you get as well the privilege of distracting on those screws to allow you to get better access to the disc space as well. We're going to be demonstrating the one in the middle today, which is called the mass TLIF retractor. Now, once you get down there on that facet, it's very important to burn everything on top of that facet. You don't want any bleeding. You want it to be very clear when you're doing your osteotomy and taking that facet out. So make sure that you are in bone. Make sure that you see that joint line so that you understand the anatomy exactly. Now, once you do that, there are two ways of doing your facetectomy. Obviously, you can use the high-speed wear, whether you like doing cutting wear or diamond wear. The problem with that is once you do that, this is the only source of autograft that you have in this surgery. This is not an open TLIF where you have removed all of this and you have enough bone graft to be used in this space. This is the only one that's going to have removed from the patient during this surgery. So if you're really keen on having your autograft, then probably a high-speed wear is not the way to go. That's why I use in those cases an osteotome. And a number of years ago, I was doing this surgery. I used to do my osteotomy without using a C-arm, and then I realized, I talked to Richard Fessler, who was one of the first people to describe an MIST. And then he opened my eye to the point, you already have a C-arm that's going across table, because you have already placed your screws under C-arm. So why not take a couple of shots when you're doing your osteotomies to make sure that you're not injuring anything and you're not breaching the pedicle below and the pedicle above as well. So all you need is just 3 cuts. Cut for the lower part of the facet, the upper part of the facet, and then a medial cut, and usually that facet comes out completely as one piece. Once you have done that, you can complete the rest of your facetectomy with a Kerrison, if you haven't removed just one piece, and then the rest of it is basically a classic open TLIF. You have an access to the disc space, you're using your shavers, using your curettes, doing a classic TLIF. Now remember, when you're doing an MIS TLIF, again, it's a fusion surgery. Right? The fact that you're doing it through a minimally invasive approach, that doesn't mean that you're cutting any corners. You need to decorticate those end plates very well. If you do corticate the end plates in an open TLIF well, you need to be even more meticulous in an MIS TLIF. And why is that? Because you don't have any post-lateral fusion. You're depending on this space for fusion. So you need to make sure that you have removed the majority of that disc and you have done enough decortication of the end plates. It's a very good practice when you start doing these to use a curette that goes all the way to the contralateral side. Don't hesitate to take a shot and baby shot. That you went all the way to the contralateral side. Pseudoarthrosis is reported in the literature to be higher in MIS TLIF, actually in the older literature, simply because the majority of the surgeons will go in there, do a half discectomy, an ipsilateral discectomy, push a cage in, x-rays look great, 2 years down the road the patient's coming with pseudoarthrosis and broken screws. It's all about fusion, it's all about doing proper discectomy all the way to the contralateral side as well. And now regarding the options of bone grafts, obviously you can use that facet that you removed earlier, but that's not enough, because that's like 1 or 1.5 cc's or a maximum of 2 cc's. We always need to augment that with biologics as well. Now if you live in an area where biologics are expensive, you can always get an immediate crest bone graft, and there are several ways of doing this. I'm pretty sure the majority of you have taken immediate crest bone graft before. Cage selection. Should I use a banana cage, a bullet cage, a boomerang cage? Now the truth is, there are several studies out there that show that there is, in biomechanical studies, there is absolutely no difference whether you use a banana, bullet, or a boomerang cage. Did anyone see this before, anywhere? No one. Like, it's in a lot of papers in the literature. I haven't seen it myself. It's probably one of the very oldest implants out there. Now, should they use titanium peak or titanium peak cages? Now, the recent literature is moving in the direction that you are going to have much better fusion if you're using titanium cages, particularly 3D titanium cages. Now, I had pseudoarthrosis with both, with titanium and with peak as well. All right? So, the point that I want to highlight on is all about how much work you're going to do on that disc space. All right? At the end of the day, yes, the data is better in the direction of the titanium, but the cage is not going to do magic if you didn't do enough work on the end plates as well before getting that cage in. Now, does anyone know what those are?
Dynamic expandable.
Any of you are using expandable cages?
In Auburn.
Alright, so a couple of you are using expandable cages. Most important thing to know is expandable cages are not going to do magic. They're not going to create the low doses for you. It's the amount of release, the amount of discectomy, your facetectomy, your bending of the rods, that's going to create this low doses. This is a device just to fill that void that you created. So don't push the envelope with the indications of using expandable cages, because we actually conducted a study a number of years ago comparing expandable cages with static cages. What we found that 1 year down the road, there was absolutely no difference in the local and the global number of doses. As a matter of fact, we had a higher incidence of cage subsidence when you use these kind of cages. So don't push the envelope in expanding those cages. Now, you wouldn't spend much time on this. Is MIS TLIF more expensive than Open TLIF? Obviously, it depends on where you practice. Here in the UAE, it's pretty much the same. Whether you're using an MIS TLIF or an Open TLIF, there's not much of a difference because the cost of the screws and the cost of the cages are almost the same. But what I can say that even in other countries, there's the cost of infection, the cost of readmission, all of those things are taken into consideration. And also keep in mind, here in the UAE, for example, we take the operation time by every 15 minutes or every half hour. 1 minute in the United States, $60. 1 minute in the law. So just standing over there and saying a joke, that's probably $120 extra on top of the surgery as well. Alright? So that's something that you need to take into consideration whenever you do those surgeries. But I wouldn't bore you with all those papers. What I say is in the majority of the literature in different parts of the world, there is not much of a difference if you take into consideration everything, including the cost of the implants, OR time, readmission rate, the cost of infection and antibiotics, and all of this into consideration. There is absolutely no difference between both. So back to our case over here, classic case that we see every day in our clinics, and that's the case that we did in MIS TF4. Now this is the banana cage, the banana titanium cages, and again, you cannot turn those cages all the way to the other side unless you have done the work on the other side. You've done a discectomy, you have removed the disc on the other side to get that cage to go smoothly to the other side. Thank you very much.